Hello, I'm Sujit Rajan, consultant pulmonologist at the Bombay Hospital Institute of Medical Sciences and Bhatia Hospital in Mumbai. And I welcome all of you to Season 2 and Episode 9 of Healthcare Superstars. As you know, in the first season, we have seen some amazing cases within the interstitial lung disease, COPD, and asthma series, which have been really well received. In Episode 9, we based on audience demand, again a move into the asthma era with an important concern in respiratory medicine, which is asthma management and COVID. So in today's episode, we shall be addressing this much debated issue of managing asthma in a COVID era. And before I move forward with inviting our speakers and faculty today, I would like to first thank our collaborators, which are the Sri Lanka College of Pulmonology, Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPath from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. So let me introduce our first guest for today, Dr. Umesh Lalu. Welcome, Umesh. Umesh is extremely well qualified, as you can see. He was the former dean of the Nelson Mandela School of Medicine at the University of KwaZulu-Natal, the past president of the South African Thoracic Society, the chair of the Adult Asthma Guideline Committee of the South African Thoracic Society, the Vice President of the Society of Pulmonologists of the Indian Ocean Islands, University of Technology, Professor, Durban University of Technology, Principal Investigator of the International Clinical Trials Research Site of the US Division of AIDS, Executive Director of the Enhancing Care Foundation, a pulmonologist in private practice today, and has over 100 peer-reviewed publications. And my other colleague and faculty is Dr. Naveen Govinder. Naveen is the CEO and Deputy Chairman of KZN Doctors Healthcare Coalition and a family practitioner in Phoenix, South Africa. Naveen is also a recipient of the 2021 Outstanding Services in Healthcare Award and the 2021 ASA IPA Digital Healthcare Innovation Award. Naveen has co-founded Vaccines for Healthcare Workers, an organization that promoted vaccination of healthcare workers in the private sector in South Africa, has a keen interest in asthma and other respiratory diseases. So welcome, Umesh and Naveen. And Naveen, over to you to present the first case.
Thank you, Dr. Rajan. So before I start, let's put you into the setting and the environment that my case is from. So I'm a general practitioner practicing in primary care as a GP, as a medical doctor in private care. I'm based in Durban in South Africa, that's on the East Coast. It's a seaside town. So my case is from the beginning of the fourth COVID wave that we've experienced in South Africa, and the Omicron variant had been identified at that time. My case is of a new patient, so I've never seen this person before. It was a 54-year-old female, and she presented with an acute shortness of breath, which had started about 24 hours, well, in the last 24 hours. She could not complete her sentences. She looked unwell. She describes a flu-like illness for about a week preceding. She says she has not been treated, she has been treated for wheezing as a child, but has not been on any particular therapy. And from my side, she had not been vaccinated with a vaccine.
Naveen, as a primary care physician, what all comes up here in you? Is this bronchitis? Is this COVID? Is this anything related to an allergy, a drug allergy, you think?
So, with the acute presentation, and with our brain waves being constantly bombarded with COVID the past year, the only thing that came to mind was, could this have been COVID? This patient was distressed. The flu-like illness fitted in. the history of no vaccination fitted in, and it was the typical presentation that most of our patients were coming in with at that time. With the history of wheezing, it alerted me that there might be something else to this. But again, very aligned with the flu-like illness and the COVID pandemic that we have been experiencing.
Sure.
This patient was quite distressed, could not get a decent enough history to go into details with her. So I had to act.
Sure. And just to understand, Navin, would you see these patients in clinic, a patient who presents like this, or would you see them online, just for primary care physicians to have an idea with this kind of a history in today?
This kind of patient would normally present in a face-to-face with myself. I rarely do practice virtually. I have done a few consultations, but it is not simple because you cannot examine the patient. You cannot get the physical cues you get from a physical examination when you're seeing that patient.
Sure. Umesh, just a question to you, Umesh. If your secretary told you about this history, would you schedule face-to-face?
Definitely. I think, when the virtual consult is okay when you're following up a patient that's known to you.
Sure.
I think like this presents in some form of respiratory distress, generalized flu-like symptoms. You need to see the patient to understand what's going on.
Sure.
When they mentioned that this patient had a history of asthma but did not take the treatment for the reasons presented, then all the more need to see this patient because clearly there is something acute going on.
So the clinical picture, when you eyeball the patient, she was obese, she was distressed, she was tachypneic. We had managed to do a blood pressure on her and it was elevated and she was tachycardic. Her oxygen saturation was low, around 82%. On examination of her chest, there was reduced breath sounds and a minimal kind of wheezing scenario, but not an overt asthma attack.
Sure. So this was obviously a patient who is hypoxic now, first time presentation, minimal wheezing, and a blood pressure that's elevated. Navin, what do you do here? What do you do here?
Yeah, so typically what we do is we follow our ABCs. We make sure the airway is open, the airway is patent, which was obvious.
Sure.
We follow on to the breathing and then we assess circulation. So we were stuck on breathing with her. Typically what we would do is put a patient onto oxygen and then assess further on whether we need to nebulize such a patient or advance care.
But if you thought this was COVID, what would you do? Because I think there are too much panic in primary care physicians around that a hypoxic patient coming first time to their clinic is COVID. That's what we often see. So would you take any precautions there before you nebulize or any other do's and don'ts?
Yeah, so the precautions are already set at our practice and at most practices in the area.
Yes.
Full PPE at all times, social distance, one patient at a time, no family members or non-patients to be in the consulting room or in the vicinity of the patient. We have access control with questioning patients at the door. Are you here for a chronic visit? Are you here for something that might be a flu-like illness or a COVID-like illness? So immediately we kind of try to triage whether this patient is an infectious patient with a risk of spreading a virus, whether this is not an infectious patient. In either circumstances, PPE is on at all times. So the confounding factors we have in this kind of scenario is, what do we do next? In view of this being a distressed patient, she did have a mask on, but with a distressed patient, there's this constant urge for them to kind of pull the mask down so they can get more air, they can get more oxygen into their system. So we have a separate room, a separate space that is used for any kind of distressed patient that we suspect might be infected.
Love to hear what happened from here, please.
From here, it just didn't get any better. We had a oxygen crisis in South Africa, where we did not have enough oxygen and cylinders being manufactured or distributed in time to replenish what was lost. And I had just run out of oxygen at the practice that morning. And I'm stuck. Is this a COVID patient? Do I nebulize this patient with the risk of the airborne transmission of COVID? Do I administer steroids to this patient? Because there was this wheeze. And if I did administer steroids and it was the acute viremic phase, this would obviously make this a bad COVID infection and pneumonia and all of the consequences thereof. For sure, we knew that the patient required hospitalization. But we were sitting with time issues. We were sitting with a sick patient in front of us. What do we do next?
Sure. Very, very challenging from what I can see here. And I would never have liked to exchange places with you, Naveen, with this patient. Umesh, any thought here? What would you have done as a primary care physician amongst these options?
We have to acknowledge we functioning in a COVID pandemic. So therefore it behoves us to keep that foremost in our mind when we're assessing this patient. So the correct assumption is this patient has COVID-19 until proven otherwise. The next step is what particular risks does this patient carry? So he noted in the history this patient may have been diagnosed with asthma in the past, but not on treatment. So we probably see a patient with a background of undertreated asthma and then probably developing a viral illness. And in the pandemic, it's COVID-19 until proven otherwise. And then when he made the point that this patient could not speak in clear sentences, and you then consider asthma, then on first principles, this has to be acute severe asthma, irrespective of the oxygen saturation. But we already know that oxygen saturation, as he had recorded, was low. So I think very clearly his intention was to give this patient oxygen. We needed to administer some kind of bronchodilator. During the COVID pandemic, I think it would be difficult to nebulize, and I think our Thoracic Society, in line with the International Thoracic Societies, issued a notice or a guideline that we should avoid nebulizing. So there are other ways of administering a bronchodilator through a spacer. But this patient was hypoxic and this patient needed oxygen and needed to get to hospital as soon as possible.
Sure. I tend to agree there, but it is challenging. So, do you recommend administering steroids, Nevin, in your clinic? Would you give an IV steroid shot before sending this patient to the hospital, or would you nebulize? If you had a choice between the two, I would imagine the nebulizer would give immediate relief to the patient, but the steroid would probably kick in after an hour or two. So would you do both, or what would you advise the primary care physician in such a situation?
So prior to the COVID pandemic, I would have done both. I would have nebulized the patient and then administered it in view that this is an ill patient that is going to require hospitalization, and is by the time the ambulance comes through and transports the patient, the steroid would have started to work and we were getting progress. With this particular patient, we're in the middle of our pandemic. I was short of options, quite literally. What I had decided to then do was to follow on my first thought was to put the patient outside, because we did have sufficient space in an outdoor environment. And I went against the guidelines, unfortunately, and I did nebulize the patient.
Okay.
I had also administered an IV corticosteroid, and I had called the respiratory physician to alert them of the admission.
Naveen, a quick question. You mentioned you ran out of oxygen, had run out. Was that your clinic oxygen, or was it the patient's cylinder at home?
No, it's the clinic oxygen.
So that's an important question, Naveen. I do not know a significant number of primary care physicians that actually stock oxygen at their clinic or keep a concentrator. Is this a case, or is COVID telling us that primary care physicians should either keep a cylinder or a concentrator at their clinic?
So this was my scenario as well. Prior to the COVID pandemic, I did not have an oxygen cylinder.
Sure.
Subsequent to that, with the amount of hypoxic patients with bed shortages and literally having patients die in front of you, we promised to purchase oxygen cylinders and service them at regular intervals so that we can give oxygen in an out-of-hospital setting prior to them getting into a hospital setting.
These are things, how medicine has evolved, Nevin. It's really amazing and such important take-home. Please continue.
Yeah, so on the point of the technology and the advancements, if we look at just an oxygen oximeter, prior to COVID, we never kept oximeters in a primary care setting. It was expensive machines attached to ICO devices.
Right.
After COVID, we got these little finger things that you'd stick on that are battery operated, that are fairly inexpensive and fairly accurate.
Right.
It makes me wonder how many distressed patients or asthmatic patients that I've nebulized and sent home that were hypoxic at the end of it, because you wouldn't know without have testing.
Absolutely, it's helped me actually counsel my sleep apnea patients better about hypoxia in the night, because everyone seems to have a pulse oximeter. And interestingly, a friend of mine on a flight, when a patient was breathless, couldn't find a pulse oximeter in the emergency kit of the aircraft, but every passenger had one. So that tells you what has happened with pulse oximeters. So please carry on, Nevin.
So the patient was admitted and was taken under the care of the pulmonologist. The COVID test happened to have been negative, which surprised everybody. The patient improved on in-hospital management of an acute asthma attack. And after the PCR was negative for COVID, the physician had then done a extended spectrum test and had identified swine flu, H1N1, as the virus that was causing the entire incident. Patient thankfully recovered fully and was discharged home.
Fantastic. A few thoughts here, before you go to your concluding slide. This patient was probably, detected with H1N1, and I keep getting this question asked now by people who are traveling, because not many countries yet have molnupiravir and the other new oral drugs. Should you carry oseltamivir with you when you travel? What's your take on that, Nevin? Do you put it as part of a travel kit for your patient?
No, not at all. We're always cognizant about antibiotic abuse and antiviral abuse.
Yes.
When we did have swine flu outbreaks previously, we were not one to run to the Tamiflu as a first line of treatment. We managed the patient, and if there was reason for more advanced care, then we would initiate or add on the antiviral. To put it on as the standard regimen, especially once we know that the swine flu is now endemic, it's everywhere, it's part of your normal flu spectrum, and it's causing annual flus. I wouldn't necessarily add it into a travel pack.
Sure. Please carry on.
After the patient's discharge and she had sufficiently recovered, got to ask her a few more questions. She was diagnosed as an asthmatic at a younger age, but she was never shown how to use an inhaler properly. So she abandoned them. She just figured, this little thing does not work. Why should I continue using it? And she got these wheezing episodes about twice a year after having flu-like illnesses, and probably sometimes outside of that. So it was interesting to know that this was an asthmatic attack, and it was probably precipitated by the infection that she had. Sure. But I'm glad the patient is well and has been has recovered fully.
Right. I was just wondering. So obviously, if this was a previous diagnosis of asthma, this patient was never given an asthma action plan. Am I right, Nevin?
Right. Absolutely.
Yeah, and neither asked to use a peak flow meter. any thoughts for primary care physicians listening in? And Nevin, what made you so interested in respiratory medicine in primary care? May I ask, because primary care physicians listening in, there's suddenly so much for them to do. Is there any thoughts you have for them in terms of primary care management of asthma, especially related to this case?
So I think the interest is sparked from the environment you're working in, right? So we're in an environment where there is an area in KZN that has industry, and there's a lot of asthma and bronchospasm as a result of pollution in the air. We're also in an area where there's a lot of allergic rhinitis and allergens in the area. Being a coastal town, the humidity is elevated. There has been identification of some fungal spores that causes. So annually, or maybe even 2 or 3 times a year, we get numerous patients attending with respiratory illnesses, and often it's an asthmatic attack, sparked on by the allergic response and in some areas by the pollutant effect. This has sparked that interest to say, you know what, let's take this further. Let's be more interested in what's happening. When you're working in a busy environment, like a busy clinic environment, in an emergency room, in your younger days, every person that came in with an irritant or a cough or an infection, you just antibiotics and go home, and you don't have that follow-up. But working in a family GP practice, in Durban we call family practitioners or house doctors or family doctors, you get to understand the family, see the trends between the parents having asthma, the children having asthma, the allergic syndrome that goes between the skin, the nose and the lungs, and you treat that as a holistic event.
Sure.
Asthma is not difficult to treat in a primary care setting. It is easy to pick up. It is easy to treat. You do have cases that will require specialist care, and that's a given for anything. And that's why we have our specialists available. But to understand asthma, to understand how to treat your acute episodes, and to manage chronic episodes, I think should be in the spectrum of any primary care practitioner.
This case was really fascinating, and one thing that really stood out here was, in my opinion, was a lot of denial on the patient's part all these years. Diagnosed at a young age, she's now 54, and probably suffering more than she ever claimed in the last few years, but tolerating it. So this is one big issue we find in asthma. I think there are so many issues that we need to cover in primary care management of asthma. And Umesh, you've been at the spearhead of the South African guidelines for asthma management. So please go ahead.
Well, again, thank you very much for the opportunity to participate in this masterclass. I think the case presented by Nevin was very instructive and raised a number of important issues, certainly in the context of the COVID-19 pandemic. Now, asthma has many challenges to doctors in private practice, primary care practice, to patients and to pulmonologists. It's a complex inflammatory disease, but the bottom line is that despite its complex inflammatory processes, almost all patients with asthma need anti-inflammatory treatment. And I think the take-home message here is that the anti-inflammatory medication that has universal effect in all asthmatics are corticosteroids, and for convenience and reduction in side effects, it is administered for all intents and purposes by inhalation. And I think that is very important to constantly emphasize, irrespective of where we practice, whether it is first world or third world, we still face the same challenge of patients and maybe some doctors having the so-called corticosteroid phobia. And we need to reassure our patients and our practitioners that administering inhaled corticosteroids, firstly, is the most important anti-inflammatory medication for all asthmatics, and that by inhalation it is in recommended doses absolutely safe. So there should be no problem with that. GINA, the Global Initiative in Asthma Management, has introduced guidelines, and there's several advances in the guideline. And I think the one most important advance is that in the past, we treated mild intermittent asthma with bronchodilators, i.e. salbutamol inhalation as needed. It's become quite evident that even these patients need inhaled corticosteroids on board. So we still use treatment intermittently, but the recommendation is coming out stronger and stronger with more evidence that even for symptom relief, you should administer the bronchodilator together with the inhaled corticosteroid. And I think a lot of this understanding arose out of the most recent British or UK investigation into asthma deaths. And I think everybody who manages asthma should actually take the opportunity to actually read this publication. What came out of it is quite astounding, that when you look at asthma deaths, at least 10% of patients who died from asthma were classified as mild asthma when you went into the primary care asthma medical records. So what happened, or the understanding we have, is that even mild intermittent asthma can lead to asthma deaths. So that is why there's a shift towards using a corticosteroid together with the reliever medication. That's going to be a huge challenge, particularly in resource-limited countries where bronchodilators are very cheap and available over the counter, and then adding a corticosteroid just raises the cost. So there's two challenges here. Firstly, making it accessible and affordable, and secondly, to change our mindsets in managing the acute symptoms of asthma. But I think that's a tremendous advance in the way we look at managing acute asthma symptoms. I'm not going to go through that in any great detail.
Umesh, if I can just interrupt you. If you look at the new GINA guidelines, if you go back to that slide, for a general practitioner, what would you say is the biggest take-home message from these guidelines? I mean, you did mention the mild asthma guidelines have changed, but in terms of prescription, as to what pharmacotherapy they should prescribe, what would you say has changed?
So for the very mild asthmatics, chronic medication, you must have minimum low-dose inhaled corticosteroids on a regular basis. For patients who have mild intermittent asthma, you treat intermittently, but in the past, when we were giving a bronchodilator, the proposal is into the future we should be administering the bronchodilator together with the inhaled corticosteroids. So I hope in the future the pharma is paying attention and will produce the salbutamol inhalers together with the corticosteroid included in it, so there's one inhaler for reliever. So that is the most important advance.
Get it. That's clear to me. And do you think that means that's the end of the road for plain salbutamol in asthma for adults at least?
Increasingly, yes. But I think, as I said, that management approach is so entrenched that it's going to take a generation to change. But the sooner we start, the better.
Sure. Please continue, please.
So I'll proceed. So I think the key points in the new guidelines is that mild asthma is certainly associated with increased mortality. Now, the most severe asthmatics, which is a challenge, and I think most of these patients, fortunately, would get referred to physicians with an interest in asthma, or wherever available, a pulmonologist. And then there is the advent of the long-acting anticholinergics, there are biologics, and there's bronchial thermoplasty. Now, these therapeutic interventions are extremely expensive, highly specialized, and therefore this patient should be referred. Suffice to say that it's less than 10% of the asthma population that would actually need this. So the vast majority of patients can be readily managed optimally in a primary care setting. More and more, we're going to see patients even with chronic persistent asthma actually needing combination inhalers with a long-acting beta-2 agonist together with the inhaled corticosteroids. There's increasing recognition of asthma and COPD overlap. I'm not going to discuss this at all. And again, suffice to say that smokers can develop asthma and asthmatics can develop COPD when they smoke. So it's not surprising that these two diseases overlap. The take-home message there is if you suspect a combination of asthma and COPD, the simple approach is to ensure that you give a beta-2 agonist together with a corticosteroid. We know that severe asthma actually contributes to the greatest cost of asthma care, and I think there's a lot of research trying to understand the genetic basis and the pathophysiologic basis of severe asthma and how we can control these patients better. I think in 2021 and 2022, COVID-19 has really introduced a whole new insight and challenge to us in managing asthma. So just to dispense with severe asthma, because as I said, even in primary care practice, these are the patients that consume most of your resources, both in time and cost. And the commonest cause for severe asthma or asthma being difficult to control is poor adherence. And I don't think anyone can emphasize more how important it is to ensure, number one, that the inhaled corticosteroids are best administered by inhalation. It's safe, gives you the best response and minimal side effects. However, we do not pay enough attention to inhaler technique, and that is the commonest cause for poorly controlled asthma. I practice in a more first world setting, and you would think that you would not see patients with poor inhaler technique. I can still tell you that about 80% of patients who are referred to me with poorly controlled asthma actually have poor inhaler technique. So it's worth investing constant encouragement to both practitioners and patients to pay attention to inhaler techniques. But other factors that contribute to worsening asthma is rhinitis, which is about 80% of patients with asthma have allergic rhinitis. And again, in line with the United Airway concept, if you don't treat asthma, the allergic rhinitis gets worse, and if you don't treat allergic rhinitis, it either precipitates or makes asthma more difficult to control. I think occupational factors are easy to identify if you take a history, and dealing with that should not be difficult. The other challenge that I see in practice very commonly is because we have these cardioselective beta blockers routinely available, many of them have different trade names, and sometimes patients and doctors fail to recognize that these drugs are actually beta blockers. And we see many asthmatics actually having worsening in the asthma because they're on beta blockers, and that's not recognized. So we need to pay attention to that. We need to look for associated systemic diseases, certainly in our setting. And I don't know what the situation is in India, but we see many patients with hypothyroidism, but both hyper and hypothyroidism can contribute towards difficult to manage asthma. Again, in my setting, and I think it's the same experience the world over, that psychological factors do contribute to poor asthma control. So whilst you deal with the patient, the adherence to treatment, look for concomitant diseases that you need to control, you need to also look at the environment in which the patients function and deal with that so that you get better asthma control.
Naveen, a question for you here, Naveen. You saw all those factors, and I think there are all those factors. From a primary care perspective, do you think one of those factors stands out as the most important for an asthmatic whom you have given the perfect prescription but still comes back uncontrolled? Which would be the commonest?
So it's the United Airway theory, right? So when we're not treating the rhinitis, we're not treating the postnasal drips, these are the patients that will typically always come back despite using the inhalers properly. We're not treating the patient holistically or completely. We don't get a lot of patients coming through in my setting with occupational related asthma or where there's other factors. But for me, I think it's the rhinitis that's not treated.
So that's interesting. Yeah, I often see inhaler technique as an issue as well. Actually, I don't know, Umesh, even after your asthma nurse or assistant has taught them the inhaler, how often do they come back using it incorrectly?
Very frequently, and I use every doctor visit to reinforce inhaler technique, and I would advise all primary care physicians to do that. It is an investment in the patient's better control. You can teach your receptionist to do it, your nurse to do it, so it should not add to the consultation time.
Sure. So on that, the internal factor was the rhinitis. The external factor is 90% inhaler technique. And I do a similar exercise as Prof. Every single asthmatic patient that comes in brings in their inhaler and they demonstrate, what they do with it. And often they they spraying this into their cheeks, they're exhaling and then pressing the button. There's a whole lot of factors that they just can't figure it out. It's not as simple a device as one would think. And when we give a script to a patient, they go to a pharmacist and receives a box in a plastic, and that's it. It's still sealed, and often it still comes back to me sealed without the person knowing how to open it.
And Rajan, I also examined pulmonologist board exams, and one year I decided to bring about 10 different inhalers, and I asked the candidate who's training to be a pulmonologist, now can you show me how to use each one of these inhalers? And all of them failed, because in many of them train in the state sector where all these inhaler devices are not available, so they're not familiar with it. So for me, the important message is you're going to treat asthma. So your first responsibility is to make sure you are familiar with the inhaler devices so that you can teach the patient and instruct them and correct their technique.
Absolutely. Couldn't agree more, Umesh. Please carry on.
Right. So I think another big challenge in the context of inhaled corticosteroids in the COVID pandemic was this fear of corticosteroids. So there was initially a fear that, corticosteroids might make COVID worse. The fear was that asthmatics on corticosteroids now should stop using it because it might affect their outcome with COVID. And there was also a very interesting observational study that suggested that if you got COVID and you used an inhaled corticosteroid, you might mitigate the severity of COVID. And so what followed was this very good study that was published, which looked at inhaled cyclosinide in patients who developed COVID. And these are not patients who are asthmatic. And the reason I'm presenting this study is because it has numerous direct and indirect messages. So firstly, it was quite clear that using an inhaled corticosteroid, even when you're not asthmatic, when you develop COVID, did not make you worse. So it was safe. Second thing, they found that even though it was not statistically significant, some patients actually did get better, i.e., there was some evidence that the inhaled corticosteroid might mitigate the severity of the COVID infection, but that's not conclusive and we need more studies. For me, the indirect message in the study is that it confirmed that inhaled corticosteroids are safe even if you have COVID. Because there were many doctors and patients that were worried, I'm taking a corticosteroid, but to make my COVID worse. And I think the study indirectly has shown that even if you don't have asthma, inhaled corticosteroids are not harmful. So in the asthmatic patient, the message is that you should continue your maintenance treatment for your asthma throughout the COVID epidemic, even when you develop an active COVID infection. And I think we need to reinforce that view because patients constantly ask this question, and I'm going to show you some data about why asthma is not necessarily a risk factor for more severe COVID. And in fact, this is the information that is produced by the American College of Chest Physicians. And I just want to go through this because I think we need to reinforce this message. Asthma does not increase the risk of acquiring SARS-CoV-2 infection and developing COVID. So therefore, these patients must continue with their treatment. And in fact, the best outcome is with COVID and you got asthma is when your asthma is well controlled. Guideline-based asthma therapy should be continued. And that is even in those severe patients who need biologic, who are on oral or systemic corticosteroids, you should not reduce it. And the message is, use the minimum amount of treatment that gives your patient the best asthma control. And do not let COVID dictate you reducing this patient's treatment. The next question that I think people are confronted is it safe for asthmatics to get a vaccine against COVID-19? And the answer is absolutely yes. Your asthma is well controlled, you do not have an active COVID infection, you must go and avail yourself of the vaccine because that is the only way in which we're going to get a handle on this epidemic. The last question is, does asthma increase your risk of dying from COVID? And the answer is absolutely not, providing your asthma is well controlled and you do not have other comorbidities, i.e. an older patient, high blood pressure, dyslipidemia, diabetes, and obesity. Now, unfortunately, in the Western world and even in the third world, we are seeing large and increasing numbers of asthmatic patients who are obese. Now, obesity itself is a risk factor for severe asthma. Obesity in itself is a risk factor for increased mortality from COVID. So I think we go back to first principles. To summarize, asthma does not confer a greater risk for dying from asthma. Well-controlled asthma improves your outcome. And we need to constantly look at the other risk factors and mitigate and work on those so that we reduce risk factors for getting severe COVID disease or dying from COVID. So just to summarize again, to all patients should continue taking the asthma medication that maintain optimal control. Like you alluded to, all patients should have a written asthma management plan. And when you get acute severe asthma, the management should not be any different with or without COVID. And again, there are a lot of clinicians who believe that, you shouldn't do X and Y. Don't give them systemic corticosteroids during the viremic phase, but you are treating the asthma, not the COVID. We need to understand that. What about nebulizers? So there's a very interesting thing that has emerged. I don't know if you will recall, Sujit, but in the 80s, there were few studies that were published to compare nebulizer treatment versus administering a beta-2 agonist through a spacer in patients who come in with acute severe asthma. And all these studies showed in children and in adults, in COPD and in asthma, that there was no difference in the outcome, whether you gave the bronchodilator by nebulizer or whether you gave it through a spacer. So the message is that COVID-19 presented a risk. So if you nebulize, you were aerosolizing and increasing the risk of disseminating the virus. So in our practice, we now stopped using nebulizers in the ICU, in the wards. And in fact, none of our asthma patients actually suffered from not having that. And it reinforced the view that, we got used to a particular paradigm and don't change. And I think COVID for me has reinforced my view, and I think we should do a nice study to reaffirm that administering a bronchodilator through a spacer is just as good as nebulizing. The additional risk of aerosolizing a virus then is removed. And my observation, and I don't know what your observation is, but we did not see an increased number of patients coming in with acute asthma during COVID.
We saw exactly that, Umesh. We saw exactly that. In fact, the patients were so worried after the CDC put up asthma as a risk factor. I don't know if you recollect that. And I thought it came right on top because of A and the alphabetical order. And so that got everyone worried. First risk factor, asthma. And what you're saying completely, I would say, overrules that fear. And that's exactly what we saw in practice as well. Absolutely what you're saying. They hardly got episodes, barring severe asthmatics uncontrolled, who probably would do a little worse. But otherwise, asthma patients either were silent carriers or had very mild COVID.
And then we actually saw a decrease in acute asthma admission. Now, one possible explanation is because people were wearing masks, therefore these common respiratory viruses that were causing exacerbations were now being eliminated. But I'd like to hear Neven's view from primary care practice, what he observed, whether he concurs that we saw fewer acute severe asthmatics.
No, absolutely, Prof. We saw far less exacerbations, far less acute asthma attacks. We often wondered whether the patients just weren't coming in because they were afraid of picking up COVID from everybody else or anybody else that had flu-like illness. But I concur that we definitely had fewer bouts of exacerbations in asthma.
Okay, so if I can just continue, what about spirometry? And I think, we always recommend that you should have an objective measure of your asthma control, and the best way to do that is with spirometry. In primary care practice, it's a peak flow meter, but I think in the context of the COVID pandemic and during the severe waves of infection, I would advise against spirometry or even peak flow measurement unless the patient has their own and can do it in an open space. So we rather use the asthma control test or use your clinical judgment during this time, because we certainly don't want to disseminate or aerosolize that virus in our clinical setting, so we put our staff and other patients at risk. So wherever possible, you should avoid spirometry, but if you have to do it, I think there are recommendations by the South African Thoracic Society, American Thoracic Society, European Respiratory Society on how to conduct spirometry in the context of the COVID pandemic. It's not difficult to do, but providing you prepared and have the resources to adhere to personal and environmental protection measures, then it should be relatively safe. But avoid doing it if at all possible. Right, then there's another very interesting article that I just came across. And they did a study on how, because you see there's a perception that you got asthma, if you use a mask, you're going to have difficulty breathing, and therefore asthmatic patients are not going to be very compliant with the mask. And what they found in the study, and I've given you the reference in the Journal of Allergy and Clinical Immunology, that most asthmatic patients actually followed the mask guidelines better than non-asthmatics. And in fact, the asthmatic patients actually encourage people around them to do likewise. So that's a very interesting observation because, again, intuitively you would think you got asthma, therefore if you wear a mask, you're going to have difficulty breathing, therefore avoid using it. And the opposite was actually true. And that's very interesting to observe. So patients' behavior sometimes surprises us. And when you looked at asthmatics who used the mask, about half of them said they had some problems breathing when they used the mask. About 40% saw no change in the asthma perception of their symptoms. And in fact, some of them actually reported an improvement in the asthma symptoms when they used the mask. I mean, obviously difficult to explain, but I think the overall observation is very encouraging that asthmatics found no problem and were far more compliant with using the mask compared to non-asthmatics. Right, so I think that's about most of what I wanted to say. I just want to end up with reference to the case that Neven presented. Again, I want to emphasize that when your patient with asthma comes in during the COVID pandemic, treat the acute asthmatic exacerbation on first principles. Secondly, whilst it is true that most times it's going to be due to COVID, keep your mind open to other possibilities. Because it doesn't mean that because you got COVID, all the other precipitants of acute asthma suddenly disappear. So the case that he mentioned, in fact, the patient was referred to my practice. We are a group of 3 people. So, and that patient did very well. But coincidentally, in the last 3 weeks, we've had 3 patients who came in with COVID and were severe asthmatic, but actually had influenza. So we've got to keep our mind open to other possibilities and not be totally, blinded to other possibilities just because we are functioning in the pandemic.
Well, thanks, Umesh. That was a fascinating case, a fascinating overview of what's happening in asthma and during COVID times. But since we are in the middle of COVID times, we have a few questions I think that have come in from the audience, and I'll just go through them one by one to each of you all.
Hello, I am Dr. Sumudh from Sri Lanka. How important is the peak flow meter in asthma management, especially when the COVID is prevalent?
Umesh, would you like to take this one?
During COVID pandemic, we should avoid using anything that would potentially aerosolize viruses. So unless there's an absolute need, there's no need to measure peak flow during this time. If you're going to do it, then the patients who have their own peak flow meter in an open space, it's fine. If you have to do it in your practice, then you make sure you sanitize and again follow all your personal and environmental protection guidelines. In terms of general management of patients with asthma, I don't think all patients with asthma need to be prescribed a peak flow. You select those patients who have brittle asthma who would benefit from measuring it according to the asthma treatment plan or action plan that you've given them.
Sure. I think very clear messages. Another question coming is, and I put that across to you, Neven.
Patients with an asthma action plan have help preventing any episodes, and how important are they in a primary care practice?
As Prof mentioned, an action plan is critical to all asthmatics and to all patients, and for doctors to, it's part of the education cycle of a patient to say, this is the route you're going to follow. Should you have an asthma attack? Should you experience difficulty breathing? This is what you're going to follow through with. So I think it's very important. I think the steroid usage, if you're talking about prednisolone as in the oral steroids, I think that's a debate on itself, and how we manage patients with oral steroids out of a hospital setting or out of a doctor's view. Because if you give a patient a box of prednisone, they would quickly use it up as a relief to the asthma rather than using inhalers properly. But I definitely agree with that every patient should have an action plan on what to do when they have an asthma attack, and maybe even to bring that action plan over to the primary care practitioner if it's not the one that they had given it to them in the first place. So if you visit a doctor or another clinic, that practitioner is aware of what has been done or what is expected to be done.
Sure. I think it can save a life and probably a hospitalization and emergency care visit for sure. And following through on that case that you presented so elegantly. So I put this question across to you.
Hello, I'm Dr. Pramod Bhatta, consultant and practitioner, currently working at Anandra Hospital in the rural setting of Nepal. There is a few questions regarding use of steroid in asthma. There is a lot of phobia as well as confusion among doctors as well as patients regarding the use of steroid in asthma. Like how frequently could you use them, and the adverse effect of use of asthma are quite terrifying to patient as well as doctor. So if the panelists could clarify regarding use of steroids in asthma, it would really help a lot to doctors working in rural setting like me. Thank you.
Umesh?
It's very common, unfortunately. And it's surprising how many patients you see referred who've been visiting their primary care physician and not put on an inhaled corticosteroids. I think the main reason for that is they do not recognize it as asthma rather than steroid phobia per se. I think increasingly the message is going out that inhaled corticosteroids are safe. How you deal with it, I think there's always going to be, like you have anti-vaxxers, you're going to have people with steroid phobia. So I think it's about just constantly punting the position and showing evidence that as data accumulates, it reinforces the view that standard doses of inhaled corticosteroids are absolutely safe. I think the steroid phobia came up because we were using lots of corticosteroids systemically, and the Cushing's and the other metabolic abnormalities that followed sort of created the problem. The same thing is the phobia with using an inhaler. Patients come and tell me that, my heart is going to get weak. Now that's a sort of hangover from using potent adrenergic agents as bronchodilators that cause sudden cardiac death. But now we have, very selective beta-2 agonists, so it's absolutely safe. And I think that phobia has sort of gradually died. I think the same thing we're beginning to see with corticosteroids. But I think the pharma, when it sends out its reps and also the asthma societies and patient support group need to constantly put out the message that inhaled corticosteroids are not only absolutely safe, they're life-saving.
Nevin, the patient just tells you, I don't want to take steroids. What's your quick take to them, Nevin?
So the word steroid is the first term we would often not use upfront. We would say preventer. And when we change the terminology, a patient is, already amenable to it. What I want to say to my primary care colleagues out there is that we delay often initiating a patient on an inhaled corticosteroid, and that delay is the issue. We have to understand that in an asthmatic patient, their body is going to adapt and adjust to the hypoxic environment. They're getting used to having less oxygen into their bloodstream, and they sometimes accept this as the norm, and this is the best I can get, not realizing there's better outcomes out there. You have to ask your patient, how many times a week are you using this short-acting bronchodilator? How many times are you finding that you are short of breath or that you are distressed? Is it happening at night? Is it happening in the day? And once you get that kind of history, initiate a inhaled corticosteroid. And the patient will thank you for the difference that they're going to experience. When I have a resistant patient, I always tell them, try it. There's no harm in trying it. What you're taking is a fraction of the dose of a oral medication. It's a tiny microgram, and that's going directly into your lung, and it's going to act the way it needs to act. You're not going to get the side effects that people are talking about. So I think education is an important role. Terminology plays an important role as well. We are the patient advocate. The patients often would listen to their primary care doctor because they know we have their best interest at heart, and that's why we're the family doctors.
Sure. I'd probably add a couple of points there. We tell a lot of patients that we use it for small children as well, for pregnant women throughout their pregnancy, and we have a whole bunch of Olympic athletes who use inhaled steroids. It's pretty safe and very legal by the IOA. So that helps patients realize how common the condition is probably and how safe the drug is. But that was great. The next question to you, Nevin.
Hi, good afternoon. Dr. Arif Kamar here from Max Care Hospital in Salalah. I would like to know what is the cough variant asthma, and I would like to know in little more details its relation to the age and weather conditions and accompanied infections like sinusitis or lower respiratory or upper respiratory or common cold. So it would be appreciated if it would be discussed in more details with management. Thank you.
A lot of respiratory physicians use this term. Do you often label a patient as cough variant asthma?
So not in terms of the terminology, but in the terms of that concept. The patient would often, as I said in my case earlier, when we were younger and we're in the emergency room and a patient comes in with a cough, the knee-jerk response was to give an antibiotic and assume it's just an infection. But as you get more experience and you see more of asthmatic patients, and you learn to listen to the cues in the environment, and the weather has changed and the asthmatic attacks are increasing, you learn to understand that this cough that a patient has is not necessarily an infective cough, but it's the allergen causing the asthma attack to precipitate that cough. We also have built-in protocols when a patient comes in with a cough, asking the history and examining the patients and looking for, the obvious is the infective cause. But then when that doesn't respond, then look at other causes, look at whether this is in fact an asthmatic cough.
Sure. Thanks. Thank you, Nevin. And the next question, and the second last question to Umesh.
What is the role of Leukotriene modifiers in the management of asthma?
I hardly use them, but I'd love your thoughts on this.
Glucotrine modifiers have an anti-inflammatory effect in asthma, and they work on a specific pathway in the asthma in the inflammatory cascade. However, they are weak anti-inflammatory agents. They're effective only in patients who have what we call atopic asthma with multiple atopic manifestations, asthma, allergic rhinitis, allergic conjunctivitis, and it's taken orally, so it's an attractive drug, but unfortunately, it has a weak anti-inflammatory effect, and inhaled corticosteroids, even in low doses, trump leukotrienes in the efficacy, even in children. So it works well in the young asthmatic who is not well controlled on the inhaled corticosteroid alone and may have other atopic manifestations. So it's a useful drug in that context. So it's a low dose inhaled corticosteroids are far more effective in patients with asthma compared to the standard doses of leukotriene blockers antagonists.
I think so too. In fact, I think the only occasion I once had to use it was a dentist who wanted to use an NSAID for his patient, and I said maybe you could, for his asthmatic patient, maybe you could use the Leukotriene modifier to prevent an episode, but that's not very common either. So I guess the role nowhere close to inhaled steroids, as you rightly said, Umesh. And the final question to Nevin.
Hello, I'm Dr. Taewin, a family physician practicing in Along Township, Yangon, Myanmar. Now, I'd like to ask one question. How important is allergic rhinitis in asthma management? And how will you advise GP to treat it regularly or need-based treatments? Thank you.
How important, this is a topic we did allude to in your case and Umesh's talk. how important is allergic rhinitis in the management of asthma? And if you treat it, do you treat it with regular nasal corticosteroids or Knead-Based corticosteroids nasally?
In the environment I'm working in, I see a lot of it. I see a lot of allergies. I see a lot of rhinitis. It's almost second nature. And as alluded to, in the environment that way, and with the weather changes and the humidity, the majority of my asthmatic patients have rhinitis, or my rhinitis patients become asthmatic. So we have to treat both. The nasal steroids often work. There's technique to that as well, you with the direction that you're using it and the way you're using it and the expectations of the patient. So I would often prescribe a nasal steroid and then treat the asthma as well.
Sure. And would you use it regularly if the patient had allergic rhinitis, or come down, stop it after 8 weeks, or what's your duration? Many primary care physicians have this question.
So what I normally do is I take the cue from the environment. So when we're seeing that the weather has changed, or the season has changed, or the environment has changed, patient would often use every day. And after about 2 or 3 weeks, they see that the environment has improved, their rhinitis has improved, they go down to every second day or every third day and kind of wean themselves off it with the view or knowledge that down the line they might have to use it again.
Thank you so much. And I think in the current pandemic, Umesh, just wanted to hear from you a little bit on Omicron. Do you have some thoughts to share with our audience on that? Because everyone's been worried about it, and we'd love to hear what you have to say.
So I have a very cynical approach. All of us want to become experts in COVID and different variants of SARS-CoV-2. The issue is that we're going to learn as we see patients coming in. Our experience in South Africa, and certainly, working with my primary care practitioner colleagues, my pulmonology colleagues across the country, South Africa, firstly, I want to set the record straight. We were the first country to identify the Omicron virus. We didn't create it. So we have a very well advanced virology research setup. We're seeing a lot of Omicron, and it's a virus, there's no doubt that it spreads far more rapidly than the Delta variant or its earlier variant. But what's interesting is that we are seeing very mild patients. We've experienced the first, second, and third waves, and Neven will tell you the number of patients we've seen. They died in practice, they died in the cars, they died in our ICU. So far, I work in 2 ICUs, my team, and we've not had one COVID death yet. Others have in certain patients, and certainly in the unvaccinated. So the message, the experience we have on the ground in South Africa is that it's a virus that spreads far more rapidly, fortunately extremely mild, and if you are vaccinated, I think you have even milder symptoms, and the mortality rate is low. What I'm hearing about what's happening in Europe and in the US is a bit worrying, and I don't understand what is the exact issue there, because they got a higher level of vaccination. So there's something unique about that environment or the genetics in the population that is causing a different sort of manifestation. But maybe they're seeing larger numbers, and certainly I saw the data yesterday from the Imperial College in London that in fact it is associated with a lower hospitalization and mortality rate. So I think the world over, this is a milder disease. The anticipation is, and again we're hoping, we're trying to be optimists that maybe this is a huge wave of a less virulent virus that would induce an immune response in the vast majority of the population and then kill off this whole SARS-CoV-2 viral epidemic. So let's hope for that. But in general, our view is that it's a mild disease and the mortality is extremely low.
And for patients who ask about taking a booster dose to prevent Omicron, what's your current take?
My current take is that that's the best we have at the moment, and that's what we should do. We should follow the cue from the epidemiologists and our healthcare providers, namely the government's plan. So, nobody can give me evidence that taking a booster does not work. And if you gave it to me, I would take it because I'm not going to take any risk. So until we know better, that's the best option we have.
Sure, absolutely. And another issue, probably in Europe, what we're seeing is also a much higher age group than South Africa and India, at least. I would say the average age is also higher, and the mortality continues to remain high in the 60 plus age group across the world. So do you think that's got to do with the US and Europe high numbers?
I don't know. I mean, obviously they probably have a higher proportion of older patients. But no, I get a better handle on why there is this regional variations.
And on Omicron, I think the other thing is which drug will work, because now with 2 drugs coming in the market, I'm still happy with my inhaled steroid, and based on the data you mentioned, I will continue with that. But what is your take on treating COVID? Short of the monoclonal antibody, of course.
Firstly, on the comment on Tamiflu in influenza, the evidence for its efficacy is extremely weak. Seriously, if you look at the data, I don't think, and as Nevin pointed out, it should never be part of a standard regimen for managing influenza. Then when you look at SARS-CoV-2, you look at the remdesivir data, it's extremely weak data that it did anything.
Sure.
But because we're desperate, we would latch onto anything. The data for the new drug, like the Pfizer drug that's been recently approved by the FDA, looks very encouraging. Let's see what happens in the field with people using it and what the experience is. For me, in South Africa, the vast majority of our patients just need symptomatic treatment because they're all recovering. We should not rush off and start prescribing these expensive drugs when we're not sure that we really need it and that it is actually making a difference, because what it's doing is adding to the cost of healthcare without a expected benefit.
Sure.
And I have no authority on it. We work on the ground, and when we're desperate, we do what we have to do. And unfortunately, in medicine, desperation sometimes leads us to do stupid things like prescribing ivermectin.
Yeah, I agree with you. In fact, molnupiravir, one of the concerns was, and I think that emerged out of some South African data, that if you don't prescribe it for the complete course, you're actually increasing the chances of another new mutant strain. Am I right, Umesh?
I speculate, and I've got no evidence for this, but when we use of drugs willy-nilly, we don't know what we're doing to the genetics of the virus. Maybe we are causing the resistance. Very much like we're creating multi-drug resistant bacteria, we are forcing these viruses to adapt. We don't know.
But thank you ever so much, Umesh and Nevin. I think it's been an outstanding session on primary care, management of asthma, the COVID scenario, and a few words on Omicron from you. I cannot thank you all enough for being here today, and wish you all the very best. Thank you for listening in. I would again like to thank our collaborators, which are the Sri Lankan College of Pulmonology, Myanmar Thoracic Society, AAA and AOSR from Algeria, APPM and AFMAPath from Morocco, the Iranian Society of Pulmonology, SDNCT and Pneumonaut from the Dominican Republic, the Panama Pneumology Association, and the Yemeni Association for Respiratory Care. Thank you very much to all these associations. Importantly, to inform you all, the episodes of Healthcare Superstars are now archived. To watch them, please log into the website or register on the app mentioned on your screen right now and deep dive into the world of Healthcare Superstars. Thank you to all the participants for your active participation. We have received an overwhelming number of questions, and for the answers to the same, please stay tuned for the FAQ section in the archive section for episode 9. We also look forward to your valuable feedback before you log out of the session, and I look forward to meeting you again in Season 2, Episode 10 very soon. Thank you.